My name's David Brownridge and I'm the Antimicrobial Stewardship pharmacist at Ballarat Health Services. And today I'm just providing a little bit of extra context to a project that we completed, looking to improve the quality of clinical pharmacists' contributions to our antimicrobial stewardship service. So at Ballarat Health Services, unfortunately, we don't have access to an electronic support system such as Guidance to keep track of our use of restricted antimicrobials such as ceftriaxone and azithromycin. So we rely on our clinical pharmacists completing an electronic notification form that goes off to the AMS team that includes the antibiotic being used, their presumed indication, and then assessment of whether the pharmacist believes that that treatment is appropriate or not. And that forms the basis of how we select patients to be reviewed on the AMS ward round. And it also forms a reporting mechanism that goes back to the clinical heads of department as well. So what we had noticed, unfortunately, particularly for respiratory tract infections, was there seemed to be quite a large difference in what the pharmacists were considering appropriate and then what was considered appropriate by the AMS pharmacist or the infectious diseases physicians. So to try and address this gap, we implemented a education module after we'd had very limited success doing some face-to-face teaching with pharmacists in an attempt to close the gap between what the different groups were thinking was appropriate. So the module was anonymous and probably most importantly included feedback that was instantaneous after people had selected their answers and provided sort of a detailed explanation of why an answer selected was either correct or incorrect. So the series of case studies was based on areas that we noticed were often not notified particularly well, such as sort of the differing severities of community-acquired pneumonia, and also areas that were probably not particularly well described in the previous version of the therapeutic guidelines. So an example of that would be where you have a patient who may be immunosuppressed on something like low-dose methotrexate with non-severe pneumonia, but then they automatically receive pip/tazo because of that belief that they're immunocompromised and therefore should be treated with pip/tazo. So before this module was introduced, the concordance between the clinical pharmacist and the AMS pharmacist in their assessment of appropriateness was about 43%. And this increased up to 73% after the module was implemented. And pleasingly, at 6 months out, the concordance was still 70% between the two groups. And what was really pleasing as well, that we were starting to see a lot of the key teachings coming through in the notifications that were being submitted. So we were seeing people starting to talk about CORB score when explaining why either some ceftriaxone and azithromycin was not appropriate for a particular pneumonia patient. And then they were also documenting as well that they'd spoken to the treatment team or the treating team to try and address this error. So lastly, I'd just like to thank Adam Livori for his assistance with this project, and also to all of the pharmacists at Ballarat Health Services that have participated in the module, which has since been updated following the release of the most recent therapeutic guidelines. And it also is now shared with new staff joining the organisation to complete within the first 4 weeks of their employment. And I'd also like to thank the pharmacists as well for continuing to do all of their notifications to the AMS team and helping out the AMS service. So thank you.